Let's see, mate. Tell me a wee bit about your, I guess, the scope of your role and your responsibilities, please.
Okay. Well, I'll say it's always in flux, and I'll give you examples. So when I first came here, I was in charge of not only the medical group, but materials management, the traditional finance areas, patient accounts, finance. It included HIM medical records as well. Let's see. I think that's all here. And then over the years, the CEO has sort of assigned and then reassigned positions. So at one point, I had case management, laboratory. I let go of the medical group for a period of time, then I got it back. I have rehab therapy right now. And Hayward Healthcare is also in charge of part of our system. We have the PPS Hospital, Hayward, which is about 138 licensed beds. As part of the system, we have Athol Hospital, which is a critical access hospital, 25 beds. And then we have our medical group. It's about close to a $20 million organization. And
you
overall,
really
go ahead.
I was going to say, you really do wear a lot of different hats.
Yeah, in a smaller place, that happens.
It's a bit of a necessity, really, isn't it?
Yeah, I think, as various other VPs have left, the one who's here the most gets the most, I guess.
Talk to me a little bit about some of the things you've got down as your priorities. You've got, first one is the new electronic medical record system. Are you putting Meditech in, or?
We haven't made the final decision. We're down to Meditech and Cerner as the finalists, I'll say. And that decision probably won't be made for another couple months.
Okay. Is there and right now, what do you have in place as it stands today?
We have the old version of Meditech. It's called Magic.
Yeah, we've actually got a couple of hospitals there, well, several hospitals there doing the Meditech upgrade. And one of them has been 2 years, $10 million, and they're most annoyed because somehow, some way, they didn't appreciate that it wasn't really an upgrade this time around as much as a brand new system.
Yes, I know we're going into it as, since our system is so old that no matter if we pick Meditech or not, it's a brand new install.
Yep, which is exactly the right way of looking at it. You've got here establishment of provider-based clinics. Talk to me a little bit about what's going on there.
Okay, so this is a fairly recent development. We are looking at our medical groups and looking at the potential additional reimbursement of making our medical groups provider-based. And so we have most of our specialists are in our medical office building, which is attached to the main campus. So as you know, the provider-based rules have changed, but we're still eligible for some of our specialists to become provider-based. So it's significant money for us. There's a lot of, as you can imagine, politics now having to become under the hospital and joint commission rules and, all of those good things. We're going through the sort of painful process of converting now and getting ready.
How far through this process are you?
I would say we're maybe 25-30% through. We have not done the attestations to Medicare yet.
Yep.
And the clinics have not been approved by DPH, which is a requirement. We're getting how are we going to bill. We have multiple billing systems here. The docs are billing currently through Athena. How is that all going to work? Yet trying to make sure we meet the regulation of integrated medical records. And so there's a lot of operational details we're going through now.
Okay. How in terms of how is your operating performance? How are you functioning as an organization, doing as an organization these days?
So we have been profitable since 2010 with the exception of last year. We lost $1.4 million from operations. We'll end up making money in total, total bottom line, but not from operations. And that's the number we really focus on. Because the others are investment related, and how the market goes is how that non-operating revenue goes. So,
yep. A lot of topic for discussion at the meeting is just looking for just general cost and process efficiencies. What are the cost and process efficiencies that are available to your organization, do you think?
I would say there's probably a lot. This organization is really, I would say, difficult to change. We're sort of isolated up here in Massachusetts, north central Massachusetts, so we haven't had the, need to do a lot of changing, and now it's starting to hit, so, we're starting to feel like EMR have to change to that, which changes our process. And so I think the culture here is one of difficult to change, but we're getting there.
Yeah, I think there's probably more change on change in the last 5 years and probably the next 5 years and probably the previous 20 years combined.
Yeah.
Just the state of play these days. My wife's a nurse practitioner in her hospital, and she says they're going through change on change on change. She said it's actually quite stressful there at the moment.
Yeah, I would say that's the probably environment every place is stress. I was out with dinner with friends Saturday night, and they all work in different healthcare facilities in Boston, and they're all complaining about this or that, the change either in insurance law or something their system is dictating, you name it.
Yep. Does revenue cycle, is that something that ultimately reports through to you?
Yes.
How's the revenue cycle going? Is there any scope for improvement, or are there any gaps there, or are there things that are good that could be better?
I think, one of the things we haven't done here traditionally is really look at, what we're getting paid versus contractual terms. So we're just starting to look at that right now. We have a company who's going to come in and do 2-year retro review of our claims and, match to see if we've missed anything.
Yep. What is your average AR days right now?
We're running about, we slipped a little in September. It's between 38 and 40.
That's not bad at all.
No. And our denials are less than 1% of revenue.
Wow, what have you done to keep denials so low?
I think, a piece of it, we have a centralized scheduling registration area that, unless you have the proper paperwork and authorizations, you don't get in. And that is a constant struggle because the operating people look at, sort of registration scheduling as the reasons why they can't get patients in. So we're always fighting that battle between operations and, financial requirements.
So it's that need to let everyone in versus the need to let those in who can actually give you a shot at actually reimbursing you.
Yeah, right.
Okay, okay. And in terms of, are there good options for your patients in terms of, being able to pay with credit cards? Like, is that quite a modern approach?
Yeah, so we have on our website, you can pay by credit card. You can, call in and pay. There's all different avenues to pay.
Okay, okay. And in terms of physician alignment and sort of productivity around your physicians, what sorts of things can you do to make your physicians more productive?
Yeah, so that's a big issue here in terms of physician productivity. We have a lot of patients, and I'll say physician labor pool is tough to recruit in this area. So our primary care physicians are really overwhelmed if you hear them speak. So we have utilized a lot of mid-levels to help support the practices. The new thing that has come up is to talk about scribes in the practice. There's a thought process, the docs are screaming, oh, I can't see more patients because the Athena EMR, what's required takes so much time. I'm sitting in front of the computer and I can't see patients. And so there's talk about, well, to have an MA medical assistant / scribe that works with the doc, that the doc then doesn't have to sit there and do a lot of, typing and going through the screen. The MA would do all that stuff for the scribe. So we're trialing that now in some of the practices to see if it actually does have a, benefit.
Okay. Okay. How is your organization? Are you going down this whole population sort of health management sort of track at all, or are you
No, not really. I mean, down the road, maybe 5 years out, I might be able to see it. But right now, where we are located, we're not in the population health arena. What is new in Massachusetts is going to hit next year is the Medicaid population has gone to accountable care organizations.
Mm-hmm.
And that will start with the population health arena.
Yeah, Massachusetts is different in a few different ways, isn't it?
Oh yes. I mean, we were the first ones to have, the requirement everyone have health care. It definitely made a difference here. Our bad debt went from like 6% to 2%.
Yep. All got better. What would you want to take from this meeting? What will be a good outcome from you at this meeting? Like, what do you want to hear from your peers?
One of the things we didn't talk about yet is, we have various debt financing we're looking at, and we've sort of done it piecemeal across our organizations. I would like to hear a little bit about, what are some of the debt options out there that exist today. I know there's a lot more like private placement debt that's available.
Yep.
Versus the traditional, HEFA and those types of things.
Okay, so some real life options. Okay. You've got here on your form, what was it? Revenue cycle optimization is a high priority. What
Yeah.
element of revenue cycle do you think you can actually optimize?
I would say coding is one. If there's one blip that happens here at our institution, it's, like in August, just before we closed the financials, I had 2 coders go out on FMLA all of a sudden. And so, holy cow, how do I keep that coding going so I keep the bills going?
Yep. Yep. See. And is that how, from a revenue cycle perspective, it sounds like for most parts, whether it be collections or whatever else, right now it sounds like you're doing for yourselves. You haven't outsourced much of this. You've got total control over it. Would that be fair?
We have some, I'll call them remote coders that are independent contractors, but if my IT system goes down, whoops, they're not productive for the day.
Yep. Yep. How about the CDI training and all that? Is that going well?
So we do have a CETUS program here. It's is it going well? It depends who you ask in the organization. Our case mix hasn't really blipped up the way you would like to see. I think it's a matter of who we have in the role more than the process or program. We utilize the 3M CETUS program, and the 3M system I think is very good, but you need someone who stays on top of it, a manager, and is aggressively and working with docs and educating the docs on, this diagnosis, you should be performing this test, or did you document this or that, And I don't think we're as aggressive as we could be on there.
Okay. Good. Mate, before I let you...
The one thing, back to CETUS for a second,
Yep.
The one thing I'd be interested in hearing is what people are doing around staffing. So calling different colleagues, I've heard everything from, no, an RN should be doing it and they're employed. Then I've heard, no, we outsource. Then I've heard coders doing it. So I'd sort of like to hear what others are doing around that process.
Okay. Good. Any other questions from you to me before I let you fly, mate?
Just in terms of sort of logistics,
Yep.
I forgot the lady's name, but I haven't booked any airfare yet. I haven't talked to anyone about that. Is that going to happen later on? Or?
Yep. I'm going to get someone to reach out to you, and we'll work backwards from there.
Okay.